Jared,
Hey, Karthik.
how are you?
Good. How are you?
I'm good, thank you.
Happy Wednesday.
So it is. It's a good Wednesday.
Yeah. Yeah. I'll have a few
Fall,
folks
can't beat
logging in
it.
here and then we'll get going.
Standing.
So, you preparing for any like conferences coming up? Like any events? You're going to be
I do
anything this fall?
have doing a conference. Actually on a panel in a couple of weeks, and in Chicago, and then we've got some stuff coming up in Q4. But this is my favorite time of the year. Just the cusp of summer and fall just gets a little crisper, right?
For
Jared, where
sure.
are you again? Where are you again? I forgot.
Well, I'm in Phoenix, so
So it doesn't
we're
really
a little further out, but
it went from 110 to 104
it is this
seriously.
time of year. It gets a little, yeah, the ready for the crisp, ready
Got
for
it.
that to come soon.
Yeah,
But
yeah. It
I agree, it's
it has
coming
a little bit more meaning in the Northeast for sure.
for sure. And we'll welcome everyone else here too as we're getting going. I think we might have a few more uh, joining us here in a little bit, but we'll get going here in just a moment with our first spotlight call, kind of a slightly different format, but built on our think tank um, audience here. So just wanted to thank everyone who's joining. I'll intro Karthik really quickly and then kind of let him take it from there. The idea for these is to truly have it as kind of a town hall format. So in our think tank sessions, one of the things I love is that it can go any direction we want, and everyone has opportunity to jump in and contribute to the conversation. The goal of this format, we just saw a need to be able to have really access to some of the experts we've had on the podcast in a similar format, right? So, meaning anyone has an opportunity at any point to kind of jump in and ask something. I think we'll lean on the experience of those who are on the call to say if you're on this call, you've been on a think tank chat before. For the most of you have, where this is a safe place. This isn't hey, let's really uh, throw in some gotcha questions for people, right? Like we're everyone here is genuinely excited to learn and interested in this topic. For those of you who haven't had a chance to listen to Karthik's recent interview on the podcast, I'd encourage you to do so, just because I think we'll cover a lot of the same things here today, but some of the insights about consumers really floated to the surface in that conversation. So um, I'll share a little bit more about that, but first let me welcome Karthik Ganesh, so CEO of OnMed, to the group here.
Thank you. Thanks, Jared. And
So in the
nice meeting all of you.
podcast, and maybe tell us, remind everyone where you're based and a little bit about OnMed, and then I'll turn it over to you here in a moment.
I will actually get into a little bit about OnMed in my presentation, but I live in Connecticut, in Greenwich, and we're based out of White Plains, New York.
Fantastic. And how long has OnMed been around?
OnMed's been around for about 8 years. I joined about 18 months ago, and that's really when we kicked off the commercialization of the product, if you will. So it's been a fun ride and looking forward to walking you guys through it.
Awesome. The couple of things that stood out to me from our podcast interview were just again one of the things you may have even seen on LinkedIn and YouTube. We've thrown one clip from that about patients having split personalities. It's one of the things I know you're going to get to, but it's one that stuck out from that interview because I think we can all relate about how we as consumers think about the actual medical care differently than all the other aspects of care. And in one thing, we're like, yes, please give me the best of care. And then the other side, we're like, I'm paranoid. I don't want to share anything. I don't want to give my data to anybody. I'm worried it's going to get in the wrong hands. And it's all about the same care at the end of the day. But that's just one insight here. With that, let me turn it over again. The goal is Karthik will go for a little while here, just to share a little bit of background about the company, and that just gives us the context for the conversation about right, like why we're going to talk about care stations. So, kind of a clinic in a box, kind of a newer concept, in terms of it actually being commercialized and actually deployed. A lot of learnings that have come from that. And I think that's just the basis of the conversation here. So I imagine there might be questions from the audience, later on about the deployment, about that type of feedback, and about what you're learning as you go about um, like the how you pivoted from a consumer model to a B2B model and things like that. So I won't steal any more of your thunder. I'll just turn it over here
No,
and
let's do it. Let's do it.
guide
Jared,
guide
just
as long
one
as you
quick
want.
question. Is the audience primarily healthcare or non-healthcare? Just so I can tailor the
Uh,
message accordingly.
Healthcare.
Healthcare. Okay. So
Yep.
and some of the numbers I share and as we go through this, I feel it will resonate with you, and some of the numbers might be starker than you thought they were, but ready to jump right into it with you. Looking forward to this conversation. Okay, sharing is not turned on. I'm going to send a
Oh,
request, Jared, for you to be able to allow me to share.
all right. See if it works
Okay,
now.
okay. Um, it should. So I am now going to go in. Nope, that's the wrong share. Stop share. I'm just right there. This again. Yep, there you go. Right. So thank you again for having me on the spotlight with you. So the way I'd start this conversation of is, and sounds like we've all been in healthcare for a bit here. We live in America, first world country, arguably the richest, the most powerful country on the planet. Um, we think of, as we think about ourselves, we think of things like power, electricity, that is. We think about water, clean running water. We think of these utilities as almost a given. We think of these as just core to who we are. What seems to be lost in the equation is why don't we think about healthcare that way? It is as personal to us as electricity and water is, and we still don't think of healthcare that way. So imagine if we had 80% of the country with unreliable electricity, or 120 million people lacked clean water. How would we feel about it? And yet, that's exactly where we are from a healthcare standpoint. As we think about our infrastructure, and again, I mean, I've healthcare access has been a long time passion of mine. I have been on the benefit side of the house, primarily with open networks, primarily for this reason that I don't believe squeezing the network is the way to get to the answer, to get to the right cost answer. But now sitting on the access side of the house, the numbers are just so incredibly stark. 80% of US counties with multiple care deserts, 120 million Americans with insufficient access to healthcare, and in most cases, in over 90% of the cases, with absolutely no primary care or no primary medical home. 3-hour average wait times. We have for ERs, we've got, as we're having conversations with EDs across the country, the first thought process that comes to mind for them is, well, we might not have space inside the ER. This is going to be placed right outside of it because the CareStation is EMTALA compatible or EMTALA compliant. But I've got these gurneys outside. What am I going to do with that? Because we have fundamentally tuned ourselves to the fact that gurneys are a part or an extension of the ED environment. That's who we are now. Absenteeism, 225.5 billion. This number continues to grow at a furious pace for employers, especially in a post-COVID world. 31 days average wait for a doctor's appointment, which for most of us is, that's the published number. So obviously, someone's had a hand in the published number because that is not reality in terms of how we live it, but that is the number that we know. And now, especially on the heels of some of the changes with rural health, 33% of rural hospitals are at risk of closure. The the important number with that, the reason I come back to the 31 days before we leave the slide is it's important to just hone in on what it means to be underserved. When we think underserved, again, I know I'm talking to healthcare veterans like me on this call. even for us, we think underserved, we think about, is this maybe poor America? Is this maybe rural America? It really is not. Underserved has no bearing on your pocketbook or where you live. If you're waiting 3 months for a doctor's appointment or 4 months for a doctor's appointment, you are underserved. That is not who we are as a country, and that's not who we should be. Let me take that back. That is not who we should be, but that is who we are as a country right now. Right. So, and when we think about access and we take purely a continue with the infrastructure conversation that we're having, the numbers I shared are really a here and now. As we look at demand for care and how it continues to grow, we know 3 out of 4 Americans, according to the WHO, are either overweight or obese. We know we have an overweighted percentage of people with chronic conditions as adults. 11,000 Americans aging into Medicare every single day. And in the last 5 years, we haven't put the number up here intentionally, but in the last 5 years, we have seen a 33% spike in Medicaid enrollment. We're getting older, we're getting sicker, we're getting heavier, and in some cases, we're getting poorer, which continues to just exponentially grow the demand for care and the need for care. And then we look at the two modalities of care that we have known historically. And I almost qualified these as a pre-COVID, post-COVID, even though nothing much has really changed. The traditional in-person care environment, clinics would be the prime way to think about it. Extremely expensive to stand up, extremely expensive to operate, 2 million plus initial stand-up costs, 500, conservatively 500K to operate year over year. We've tried our darndest to find out if AMA published a number after 2021 for the clinician shortage. I don't believe they have, because they probably said there's no policy change. Why do we keep making ourselves feel bad about this? We needed 200,000 more clinicians as of 4 years ago. We're producing 17,000 a year, and an overweighted percentage of who we have practicing medicine today are either pre-retirees or have stated they're burnt out coming out of the COVID window that we were in. So then we go through COVID and we think, so we've clearly hit it. As it pertains to brick and mortar care, we've hit a ceiling. Ceiling that there are no policy decisions or no fundamental changes that we're making as a country that will address that ceiling or alleviate that ceiling. Then we look at telemedicine. Went through COVID, we thought this was a silver bullet. For those of you who watch college football, countdown, ESPN, and Lee Corso's words, not so fast, my friend. It is, we have 70 million people without viable access to broadband. When you have a clinical experience that lacks vitals, lacks scans, that lacks diagnostic tools, you know you are going to hit a wall as it pertains to your the clinical, the overall, the comprehensiveness of the experience and what the patient leaves the conversation with. We also know, and these are published numbers, over 85 to 90% of all outpatient visits today have a telemedicine recommendation to them, yet telemedicine continues to be less than 8% of all outpatient visits as a country. Telemedicine gives us the scalability. It is brilliant in its conception, around for about 20 years now, right? But it has hit a ceiling. In-person care gives us the comprehensiveness, gives us the comfort, it gives us the psychological confidence as a patient. We've hit a ceiling. We can't throw the baby out with the bathwater. I think most of us who hear people say, well, what if we had to start from scratch again? We roll our eyes because, it's a ridiculous conversation to have. You can't start from scratch again. You almost have to take what works with what you have and then neutralize the weaknesses. Amplify the strengths, neutralize the weaknesses, which is what we have done with the CareStation. The OnMed CareStation, think of it as a clinic in a box. Um, Let me walk you through the experience in a nutshell real quickly. It's an 8x11. Think of it as a kiosk. It's an 8x11 kiosk. You can walk into it. You can roll into it based on whether you're on a wheelchair or not. It is completely accessible. You go into it. The bulk of the floor is your weighing scale. When you're standing on it, there's a 65-inch screen in front of you. You press start. The clinician shows up, not an avatar, not a bot, a person on a 65-inch screen who virtually feels like she's in the room with you. She asks you if you're ready for your visit. If you are, the door shuts, the glass fogs. You're now in a private, secure, soundproof environment. Does your intake as a part of the conversation. You've got a simple consent form. You sign on the screen. We used to have fourth grade level consent forms. As we started rolling this out more aggressively in West Alabama, we realized we needed to move to third grade level consent forms. It is not a reflection on the people. It is just health equity. That is health equity. Being able to speak the language of the person and the patient in the care station, being able to have artifacts that are easily consumable. All of this is just health equity 101, the way we think about it, without thinking of equity as a bad word here. It's private, again, private, secure, soundproof. The clinician's on with you. She takes you on your journey. At this point, your weight has been checked. There's thermal scanning. The technology is not overt. We are rolling this out in a lot of communities where technology is not a friend. They can't feel uncomfortable with the tech around them. There's thermal scanning, there's infrared cameras. It's looking for congestion, chest, forehead, sinusitis. It's looking for, it's checking your temperature. There's a blood pressure cuff, there's a pulse ox. You're asked what symptoms you're presenting yourself with. As a part of that, I've got a sore throat, I've got a cough, I've got a cold, I've got a headache. There's the scans will show it. There's a stet that deploys from the ceiling. Uh, Clinician tells you there's a patient where to hold it. You're basically holding it against yourself. She can hear you in real time. The devices are all working in concert, completely synchronous in an ecosystem where she's live there with you as if you were in a clinic. I've got a rash, I've got a bee sting, I've got a sore throat, um, I've got a earache, I've got an eye infection. High def camera deploys. You can hold it against your eye, wherever the condition might be. She can see you in real time. She's diagnosing you in real time diagnostics in play. I've got a earache, otoscope, same deployment. The visit is, as you're going through it, the visit is done. Important to note, 87% of the people who come into the care station do not require a specialist referral. 87, it is a clean, it's a significant number because the care station handles primary care, a lot of urgent and some post-acute as well. So we're really calling it everyday care. But at the end of the visit, e-prescription sent over to your local pharmacy or your pharmacy of choice, a referral to your specialist if a referral is needed, a script to your lab if a script is needed for the lab. Patient answers 3 questions as they're wrapping up their conversation with the clinician. Question number one, from an NPS standpoint, how would you grade us on a scale of 1 to 5 with 5 stars? We're at 4.96 across our book today and across our stations. If you hadn't come to the care station, where would you have gone? In 53% of the cases, they would have gone to the ER. And we know this to be a fact because 75% of the people who show up at the ER are for non-emergent reasons. And they show up at the ER because they have no place else to go, right? The third question, do you have a primary care physician or do you have someone you see on a regular basis? 78% tell us that we are their medical home. Again, it amplifies the fact that 120 million Americans who do not live in our world of wearables and what about a bot and what about AI, they don't have the luxury of that all of these are not even comprehensible terms for these folks who are just in most cases working 3 jobs. And they're worried, if tomorrow morning when I wake up, if I'm unwell, will I make my rent this month? Will I pay my utility bill? Will I be able to refill my prescription? They need a break, right? So the visit is done, door unlocks, you step out, the door shuts, UVC is run across the care station on all devices. UVC is known to kill 99.9% of all germs. At that point, once that is done, the door unlocks again and it's ready for the next patient. Right? Very simple, very intuitive experience, intentionally intuitive. There are towns we've rolled this out into. This is not a rural America play. We have rolled this out in the suburbs. We have rolled this out in rural Alabama, rural Texas. This is in downtown Atlanta, downtown Miami, downtown Hartford, in perfectly urban locations. It is inside of universities with an average return to care station rate of 37% from an adoption standpoint. Okay. When we see what our goal as we think about again, I'm going to stick with the infrastructure. This is an infrastructure play. This is a public health infrastructure play. Our vision, our goal is every underserved community, every zip code in America has a CareStation. Each one serves as a node, each one serves as an access point. People can show up at these care stations, get care. 20 minutes later, they're out of there, deployed in whether it is in your local grocery store, in your local community center, in your local senior center if you're a senior, in your children's center as you drop your kids off, and your kids are in your local school. We're actively in conversations with one of the largest charter school systems in the country to be able to roll this out. Most charter schools are in underserved communities. Um, if you're an employer, this is your absenteeism play. If you are, and especially if you're an employer like a Walmart, if you're an employer like a FedEx, a UPS, my employees are on the shop floor, if you will. If they're unwell, they are non-exempt. They have to leave. The loss of wages. Maybe they have to take a PTO day. Do they have a day? Do they not have a day? They leave for the day. It's lost productivity for the employer as well. Versus that, I've got this at the corner of my floor. 20 minutes in out. If they need to go someplace else, they go. If not, they're back at work and they're at it again. It is a win on all fronts, right? And that's really how we envision the CareStation rolling out nationally. As we think about the broader picture, again, really there is virtually no aspect of our of of how we operate as a country and as a society. There is no aspect of it: payer, provider, employer, government, housing, retail, corrections. Corrections is an interesting one. You look at it, and maybe like corrections. Really, we are inside of a prison today. In Milam County, Central Texas, we are inside of we're inside of the sheriff's office, and we are care delivery for the prison system there. Uh, we are in 7 states, growing at a furious pace. The deployments for us have been fascinating. I talked to you about the prison. We have this inside of a homeless shelter, the first of its kind, in a homeless shelter, sponsored by the homeless shelter. Our client, and that one is Catholic Charities and the local provider, Tampa General, where the MO, if you're in a homeless shelter and you're unwell, is you call 911 and you're taken to the ER. In 6 months of having this in a homeless shelter, they've had the 911 calls go down by 63%, right? We're inside of children's centers, senior centers, in universities, Hartford Healthcare, who I think, I'm not sure how many of you are from the Northeast. I think Jeff Flax is probably one of the most innovative and forward-thinking CEOs across the healthcare spectrum. He has this inside of Bradley Airport in Hartford. So it's inside of an airport. Um, the city of Atlanta is going to put this inside of the Atlanta airport as well. That's going to be our second airport. So across the country and continuing to grow. Each care station is private labeled and reflective of. So South Carolina State has their brand. It's Tuskegee has their brand. Auburn has the tiger on it. So it's every single one has their brand, and they've really personalized this in terms of them bringing care to their community with OnMed as nothing more than a conduit. And these are just some of our results here. I talked to you about Tampa Hope, which is the homeless shelter. Tuskegee University is a huge play. Lafayette, Alabama is West Alabama. We have seen 48% of the town, 37% of our visits are repeat patients. We are their medical home, and I was there maybe a couple of months ago. The lady went to the local Piggly Wiggly, showed up at the care station, did her visit. She said, "Oh, you're from OnMed." She gave me a giant hug and said, "Thank you." Um, that is a lot of America, that is more America than we talk about in the news or during election cycles or any other aspect of our lives. But that's 120 million plus people sitting out there in a lot of these places. And we're building this to scale. The problems we're solving, I'm going to stop sharing here. The problems we're solving are not American problems alone. America is absolutely our beachhead. We're looking to do this home first, do this right on the home front. And then, and I just see Zane saying, come to Canada. More power to you, my friend. I would love to. We have had outreaches from Canada. We've had outreaches from the UK. Some of the same challenges, right? Which is um, running out of docs, nationalized system. How do we get more clinicians out in the market? And the NHS has been very vocal. We were at CES earlier this year. We were the top pick. The BBC was all over us because this is a huge opportunity. So again, long story short, we know that we have the opportunity set is significant. There are some, and before I leave the presentation and I just get into questions with you, there are some things that we have fundamentally done differently about this. And for those of us who've spent a fair amount of time in healthcare, I've spent about 25 plus years in healthcare, and I feel like I've touched it from a lot of different angles. I've run a health plan, I've run a PBM, I have stood up a value-based care uh, company ground up within the broader Cigna organization. I've run a provider-sponsored health plan. We've been the back office for ACOs. Um, I think the longer you spend in healthcare, you realize, especially across all of these fronts, there's probably more lessons learned than best practices. And for me, the lessons learned have always been a couple of things that I believe hold true for healthcare in our country. One, B2C has not worked as a pure play. We have never figured it out. Adoption has always been incredibly low. The consumer is unpredictable from a revenue stream standpoint, and it doesn't matter how much money you throw at it. You look at all of the large payers, everyone is trying to work their way out in some cases, out of Medicare or the individual market at large, because they've realized you could throw as much money as you want into B2C marketing. You're not going to get these folks because consumer healthcare is not a field of dreams. If you build, they will not come. It's a given. You have to show up where they are, right? So B2C, so our play is a B2B to C play. Our clients are B2B clients. They have a variety of motivations to do what they're doing. They're not doing this out purely out of the goodness of their hearts. I'm going to call it altruistic capitalism. They're doing the right thing, but they're doing it for a variety of reasons that totally take care of their pocketbooks. Payers, providers, universities, large uh, folks in the building trades, like the second largest home builder in the country, um, local, state, federal government, just a lot of players in the equation as a part of this retail, right? So one, B2C does not work. The second, and I think Jared alluded to this up front, the American consumer and the American patient, and Zain, I'm gonna assume this relates in a similar manner to Canada as well, because this is not markedly different. We may be the same person, but we have a split personality. We feel liberated as consumers. We are okay with Amazon, Meta, etc. We're mining our data, selling us stuff that we may not even need. We're extremely uncomfortable as patients. We feel claustrophobic. Someone's out to screw us somewhere. There is some fine print somewhere that is going to come back to bite us. And there's going to be some hidden costs that I just don't know about, and it's going to be a problem. And where's my data going at the end of all of this, right? So technology for technology's sake has not worked either. You have to have tech as an enabler. Tech can't be the destination. It may have worked for wearables. It hasn't worked for care delivery. So we've been very deliberate about these models. It is a B2B to C model with a B2B play from a revenue model standpoint. It is a tech-enabled, human-delivered care delivery model. And that has been incredibly important. And the last thing I would leave you with is we have humanized the tech to the nth degree. The tech is not overwhelming. We have made the tech a friend. Where a person walks in, all they have to do is press start and they go on the clinical journey. You have to simplify it to that nth degree for people to really embrace it, especially people for whom technology is not a friend. And again, these are people who do not live in the world of wearables, AI. These aren't thought processes. And we have to be able to humanize it and deliver it in a manner that's easily consumable. I will pause with that and answer any questions you may have.
Thanks, Karthik. I can get one going. I'll just tee it up from Danny, and then if you want to jump in with any details, just the question
Sure,
you threw there in the chat, Danny, about if you can tell us any details about the tech stack of what's powering it.
absolutely. So, couple of things. One, we are a Windows shop. We're on Azure. We are our devices, even from a device standpoint, we're not a manufacturer of devices. Every one of our devices is FDA approved, and that's so we're basic. What we have done is we have built, and we're the last part of the stack. We're a Databricks shop as well. Every aspect of our what we have put our energy towards is how do we make the entire ecosystem in a loosely coupled manner come together very cleanly. And I call out the loosely coupled because it's extremely important for us that we are, by virtue of building out a loosely coupled um, architecture with a hub, an integration hub via Databricks in the middle of it to handle all data orchestration. How can we make it seamless for anything to plug into us or for us to unplug something? Tomorrow, we roll this out aggressively in the employer space. And if the employer wants us to seamlessly sync up with the Apple Watches they've rolled out to their employees, um, we see that as a huge opportunity for us because I mean I wear a Whoop. I love my Whoop. Um, my VO2 max just went up. It's awesome. So we see the care station and the clinician in the care station operating as a wellness coach. We see as we look at Embark on 26, we expect the care station to be really big from a mental health standpoint. What we do realize from a mental health standpoint is the biggest challenge is not even whether we can bring care to these patients. And we know we're in the midst of a tsunami, mental health tsunami of gigantic proportions. It's not even if whether we can bring care, it is the stigma associated with soliciting care to begin with. That's what prevents patients from showing up for mental health services. Now, if the care station is almost Vegas-like, what happens in the care station stays in the care station. You walk in, you could be there for a medical visit or a mental health visit, but glass is fogged. You're having your conversation. No one is going to, no one on the outside is going to have an opinion about what you're doing on the inside. It is going to give people the psychological comfort to seek the help they need. And when we think about that, Danny, we're going to have to be able to seamlessly plug in a mental health EMR and a set of mental health clinicians to go with it. So for us, the loosely coupled nature of the architecture, clean Windows play, some Anthropic thrown in from a code gen standpoint, along with Databricks, we've has really allowed us to do what we need to do.
Yeah, super helpful. And Karthik, really fascinated with this business that you're building. Can you speak, since you opened the door to that, can you speak a little bit to the consumer motivators? Like, what do you know about why consumers chose to use it, and what do you know about why consumers maybe hesitate before using it? Just any insights you have there around the psychological behavior side.
Yeah, the reason to not use it, it nearly always is the fear of the unknown. Um, there's a reason why telemedicine hasn't, outside of the vitals, the scans, the diagnostic tools, etc. Tech is not, tech as a destination is not the answer for healthcare. It has to be an enabler. So in communities where they've had no choice, because this is the doctor in town, or in communities where there's a lot of foot traffic, or places where there's a lot of foot traffic, comes very quickly. Places where that isn't the case, we've had to go out and help people come in and experience it, have almost have OnMed fairs, if you will, where people can come in and experience it in a safe space and understand that uh, this technology is not overwhelming. It's comfortable. It's okay to be inside of it. As we've rolled this out into schools, this has been, it's fascinating. The questions we've been asked as we've rolled them out into some of these children's centers, Danny, downtown Miami is, you know, the kid goes in, will the kid get locked out? If something wrong happens, can a caregiver go in with the person? Um, we just got asked recently, is the care station bulletproof? So though some of those questions tell us where the fears are coming from, It is not bulletproof, Zane. Um, but it's telling us where the fears are coming from. So as we think about humanizing the tech, a lot of those questions have given us, as we think about the CX, we have continued to be even more deliberate about simplifying it. And I come back to, whether you like Apple, don't like Apple, there's a lot of schools of thought on this one. What has consistently been a factor with Apple is the fact that they have deployed their tech they made ensure the tech is extremely simple to consume. We have made our tech and the care delivery that goes with it extremely simple to consume, and that's been the driver for it.
That's great. Thanks.
Question for you, Karthik. First of all, fantastic presentation.
Thank you.
Love this concept. This question isn't intended to be rude or anything, but being in healthcare research, we've seen this model before. And so
Mhm.
like HealthSpot, which went out of business. So curious, like, what are you guys doing that's different than they are, where it seems like it's working for you all
Yeah.
compared to
So HealthSpot, I would also tell you, Forward Health
Yep.
had raised close to 700 million. And they still couldn't. No disrespect to them. I mean, I think everyone had phenomenal ideas coming in. Zane, we've seen this when tech comes in and tries doing healthcare. As you follow even US healthcare from maybe 3 or 4 years ago, Zane, you had JP Morgan, Amazon, and Berkshire Hathaway came together to build out a platform they called Haven. They said, we've got over 300,000 employees. We're going to pilot this on these employees, and we're going to change healthcare in America. And it didn't work because a year and a half after that, they walked away from it. It comes back to some fundamental things again. Technology can't be the destination.
Right.
B2C has not worked. Every model that has come out with this has been B2C. You have to follow the money. You have to, I'm going to say this and it is never going to sound the right way, but anyone who starts a conversation off by telling me it really is about the patient, I roll my eyes, because if you're looking to be a sustainable business, you can't make it only about the patient. You
That's a good
have to
one.
create an unbelievable patient experience, but you have to understand who's paying the bills.
Yeah.
And you have to make it right for the person paying the bills. The flow of funds in America comes through enterprises, including the government as an enterprise. It does not come bottom up through the patient upwards. The flow of funds has never worked that way. Why would it be magically different? And so we have designed our business model, we have designed our entire way of approaching the market from again, a B to B to C versus a B to C, which is a huge difference. And that is, in my mind, that is the polar opposite to anyone who's tried this in the past.
Yeah. And I would just add, like, I love this application for like direct to employer. I used to do a lot of that work, actually consulting with a payer right now in Canada who's looking to get more into the provider space by offering some type of medical services to some of their large employers. And so I could totally see this fly to do like personal medical, urgent care, primary care, and then occupational health.
Yep.
You know,
Ahmed, definitely.
this is
100%.
fantastic.
Yep.
Fantastic.
Thank
Very
you.
I've got a question from a health system standpoint. I'd love if you're able to share kind of the business model you worked with other healthcare systems, of
Sure.
how you integrate with that, and specifically, like, is there revenue sharing? How do you handle insurance, in-network insurance type of parts? And then also, do you integrate with EMRs such as Epic or Cerner, or however you work with that?
Yeah, great question. And Joel, are you with the health system?
I am. I'm in Columbus Regional Health in Columbus, Indiana.
Outstanding. Okay. All right. So we have the motivators, and I think these will appeal to you because they will all resonate with you. One, um, we have legal guidance, which telehealth and as a pure play would never get. We have legal guidance that tells us that we are EMTALA compliant. So we could be inside of the ED or right outside of it. We don't have to be 250 yards away, which, as you can imagine, is a huge, huge win. Uh, all that is expected of us is the patient comes in the ER, the triage nurse has to triage the patient, and then can optimally redirect to the optimal site of care, versus having them sit out there and choke up the rest of the ED and hopefully supplant some of the gurneys that are sitting outside of the ED at that point in time, right? So that's one motivator. The second motivator for our health system clients has been to really own their catchment area and control leakage. So for Hartford Healthcare, as an example, goal is to own central Connecticut while starting to bleed into north and south, but there can be no leakage in central Connecticut away from the Hartford healthcare system. So they have put this across central Connecticut. The CareStation is wrapped as Hartford Healthcare, including at the airport. The airport reached out to Hartford Healthcare and said, we need you to put a CareStation in here as well. And so anyone coming in, we've synced up on our protocols with the system. That's one. Second, all specialist referrals go back to the mothership. Okay, so that's the second part to it. The third part to it is, as these systems look at catchment area and and our patient acquisition is one thing, but as they look to expand their own capacity, you're probably facing the same clinician challenges that everybody else is. How do you expand capacity when brick and mortar is extremely expensive to stand up and you don't have the clinicians to staff it anyway, right? So we have become capacity expansion for these systems. We're now working with FQHCs. We're working with Hartford Health. We've got other conversations going on, including with the MSKs of the world who are looking to use the CareStation for cancer screening as a part of what they're looking to do. The FQHCs are obviously a huge play for us, but those are some of the motivators. Just even from just a pure financial standpoint, all of these are important things. But Joel, you know this, which is the ED save by itself. It just
Yeah.
in basically 4 months they pay for their entire year's worth of contract.
Wow. Yeah. Do you require the health system to put up the capital for the unit, or how does that?
They do. It's a subscription model, right? So it is not a capital intensive project. It is not capital intensive. In fact, it is a fraction of the cost of the annual operating cost of a brick and mortar facility. And now what we're doing with Hartford Healthcare now as our pilot is we use Athena, but we are integrating the CareStation with Epic right now. So we're in the midst of that right now with them. And once we do that, what we will then have created for ourselves is essentially a plug and play layer, if you will, whether it's an Athena, a Cerner, or anybody else. We should be able to more seamlessly plug in other EMRs into this.
That's great. Yeah. Thank you very much.
Thank you.
Hey, Karthik, another question. I'm always curious, like with relatively new technology or products, how you define the category. Like I noticed you use clinic in a box on one of your slides, but I suspect that's not what you really refer to it as. What is the category, and then
Category.
and what is the consumer term that you want to see it adopted?
So we are, even from an IP standpoint, we have filed it as tech-enabled hybrid care. It is hybrid as in it is the best of traditional, the best of virtual, without any of their warts. And it's tech-enabled. Hybrid care has historically been spoken of as well. You could come into my clinic, or I can give you a telemedicine option. That is a non-option because, again, if I can't get an appointment for the next 4 months and I don't really see myself getting care in my PJs, where do I go next? And this is the best of both worlds. So it's hybrid care is how we've really positioned this, and it's tech enabled. And Zane, you're exactly right. I mean, you call it as an amenity. We really see it as we see this as a core infrastructure play. Healthcare should be as native to our needs. It is as native to our needs as power and water. Yet we have made excuses for the fact that we don't have enough access to it.
Yeah. My mind is just spinning at all the possibilities. It's like,
It's always the beauty of it, Zane. Each time I present this to somebody, I love the fact that they come up with more use cases and I walk into the conversation
yeah,
because each one is going to approach it both from a B2B standpoint and as a consumer of care,
yep,
because the applicability is so significant.
yep.
And I mean, we have gone into the market, we've been talking to folks, and MSK, as an example, came to us and said, cancer screening. And oh, by the way, not just cancer screening, even if it was just going after melanomas to begin with, that is a huge unintended black spot in our ability to know what's going on in the broader marketplace.
Yeah.
And Scott had a question about reimbursements. We have kept the model very clean, Scott, and I think Joel had this question as well earlier. So I'm sorry, Joel, I missed answering that one. So we've kept the model very clean. This is a subscription model. We are not treating ourselves as a provider. We want to be seen as a care delivery utility, if you will, that providers, payers, etc., can utilize. So we are, if we need to be credentialed inside of a payer network, we're happy to do that, and we do that in a lot of our cases for the United Healthcares of the world, etc. But every person coming into the CareStation is asked to provide their insurance information. If they decide not to provide it, that's okay as well. And our clients understand that a person might choose not to provide their information. In virtually all of the CareStations that are in the market today, and we've got over 30 of these across 7 states right now. And again, we will probably have another 40 to 50 more before the end of this year, or maybe no later than early next year. The patient isn't paying for it and is not paying for anything in the CareStation. So in the Hartford Healthcare example, Hartford takes the data that we send Hartford 2 sets of data. We send them encounter information for them to be able to do what they need to with it. We send them all the insurance information we've collected. Hartford is then sending it out to the insurers and getting reimbursed for the same. We have deliberately stayed out of trying to play as a provider because it brings complexity to the equation that immediately dilutes your ability to be effective. Because if the payer decides to upcode, and we've seen that, right? They're all going to go through the Medicare audits right now. The first finger they point is back to the provider. If we've got no incentive to make money on this thing by upcoding, it doesn't take away from the purity of our purpose and what we're trying to do in the market in terms of bringing access. It just keeps it very clean from our standpoint. That's one. Two, for a lot of these folks, they can make, without getting overly burdened by insurance-driven reimbursements, they can make their money back in spades. The conversation, Scott, for example, that Joel and I just had about the ED, putting this inside or just outside of the ED, just the fact that you can, with the ED being the largest financial cost driver for the system, if you can now get people to the right place the first time, just the cost savings alone is going to pay for this thing without having to worry about a ton of other reimbursement modalities. For the payer, it is a combination of ED saves as well as it is as they're going in with their Medicaid and Medicare bids, they have to make commitments from an access standpoint. They do not have enough access to justify what they're putting into these bids. We create additional access points for them. So as you're looking at it from a gaps in care standpoint and just provider capacity standpoint in the communities and the counties that they're bidding on, this is adding to their capacity from a service standpoint. So for a lot of these folks, the motivators are being satisfied without having an overly complex reimbursement system in the mix. And it's taking care of itself. We're going to be putting Square devices into the CareStations as we go into the end of this year because a number of folks are saying, hey, listen, I would like to do some pay as you go. Even though I'm paying for the subscription overall, I would like to do it. Square is perfect because from a compliance standpoint, PCSI standpoint, it just handles it. We don't have to worry about the credit card information and how it's being handled. And then as you think about it from the standpoint of just money being transitioned, we could basically say Square keeps 2.5%. The rest of the money transitions directly over to the payer in this case, or whoever the client is. It's a clean transaction. So again, the simplicity of our execution, the simplicity of our operating model, the simplicity of our business model has been paramount, because that is what is going to allow us to flex every which way with the fact that B2B is at the core of it.
What about staffing the physicians?
So nurse practitioners, and we have also a firm believer, Scott, that we don't have to own every aspect of the ecosystem, which is also a mistake that people have made over time as they've tried standing these things up. So we partner with a company out of Wisconsin, that has a national network of NPs. We partner, so they bring every state we enter, they have a 30-day SLA, they bring licensed NPs. We provide the technology, we provide the protocols. It is our protocols, our patient experience. They bring the NPs. They bring the collaborating physicians that are required in every one of the states to make sure that the NPs are performing in a completely compliant manner. We go after credentialing together as needed, but it gives us greater speed to market. It also allows us to focus on what we are brilliant at by partnering with people who are brilliant at what they do. We just need to bring the right ecosystem to the table. I go back again to the fact that I was just talking to somebody today and they asked me this question. And I go back to Apple again. Apple has continued to partner with Foxconn over the years without bringing that in-house, though they could probably buy Foxconn 20 times over, but they didn't do it. Focus on what you're brilliant at, be the hub of an incredible ecosystem. There is a lot you can do to be the QB. You don't need to throw the ball and catch it at the same time.
I love that. Go
We've
ahead,
got a few minutes over here, Karthik, but what I will do is I'll make sure those who want to connect with you further, first I'd invite y'all to connect with Karthik on LinkedIn, of course. But if there are any who would like your contact information, we can work that out behind the scenes. But yeah, just super excited for being able to dive into all of this, and would love any feedback from anyone who's attended, and any follow-up questions. We'll make sure we can facilitate that clearly. So really
And I
appreciate
would love to
everything.
connect with you as well. Jared, thank you. And all of you, thank you for your questions. Really appreciate your time today. Thank you.
Yeah, thanks a lot.
Thanks a lot.
Yes, guys, thanks.
Thanks, everyone.